A very good afternoon to you all. I am sure all the inspirational lectures about how grand our subject is, ophthalmology is, and how it is expanding. Everything has been dealt with in the day one and by the previous speakers. So it makes my job that much easier. I'm Arup Chakrabarti, and I have no financial interest in whatever I'm going to talk to you about in the next next 15 minutes or so. As a cataract surgeon, we have witnessed that the patient expectations have changed over the years. So we promise them that we will perform a surgery with very minimal pain or painless surgery. The surgery will be complication free, and the patient downtime will be minimal. Visual recovery will be instant, and patient will have excellent uncorrected vision at distance. And if the patient wants spectacle independence, we can use special lenses and to make them spectacle independent at different distances of functioning. And all this will come with very little personal effort from the patient, because the post-op rehabilitation is pretty rapid without a long list of contraindications or activities that are not allowed. And patients also want everything at a very minimal cost. And by and large, we have been successful in meeting these objectives of cataract surgery. But from time to time, we come across patients who are very unhappy after cataract surgery. See, for example, this particular gentleman was creating some noise outside my cabin, and I quickly saw the case sheet. I had operated on his right eye almost 10 years earlier, and it was a monofocal lens. It was a standard foldable lens, and for some reason, fortunately, he was seeing 6/6 and N6 without glasses. So he was having a multifocal vision for some reason. I'll come to it later. On the fellow eye, which I had just operated, that was a much more complex scenario. It was a very hard cataract. Pupil was small. I had to stretch the pupil, but surgery went off extremely well. As a surgeon, I was very, very happy with the outcome. And you see here, he was having 6/6 with minus 0.75. And with just plus to add, he was having N6. So what exactly went wrong? Now, if you see the second eye that was operated, because of the stretch pupilloplasty, the pupil is slightly larger, slightly irregular. And in the fellow eye, this patient, of course, had senile meiosis, and he was having pseudo accommodation in the right eye and to a much lesser extent in the left eye. And so this was the problem which the patient had, and he was not sure what was happening. And patient just also told me that, doctor, I have paid more. Of course, there's an interval of 10 years between the first surgery and the second surgery, and inflation has to be taken into account. Surgery took longer. Yes, it took longer because it was a very hard cataract and it was a small pupil situation. I had to use iris hook, more intraoperative manipulations. And patient, I also felt that there was inadequate interaction with the surgeon, with the patient, like the first eye. Like the patient was so happy, he invited me to play cards with him in Trivandrum Club, which of course I didn't do, and I had rejected his request. So there was a certain communication issue. So he was quite unhappy, even though everything have gone up pretty well. So friends, what I would like to tell you, that unlike the days of yore, like when I was a postgraduate student like you, first year, cataract surgery was rehabilitative cataract surgery. If patient has a cataract, you have to remove the cataract. That's it. But today, cataract surgery has become a refractive cataract surgery, which means you would like to hit the bullseye almost every cataract surgery that you perform, and holy grail would be 6/6. And the patients also expect to see the normal vision at the intermediate distance as well as at the near distance. So the patient expectations has improved a great deal, and we also to a large extent able to help them. So how do we meet these goals? Of course, it goes without saying that a surgery has to be very safe. There's no point in having a complex complication and think about normal visual recovery. And there are certain things that have to be taken into account. Like, for example, if the patient has a preoperative astigmatism, cylinder, that has to be taken into account with the special surgical techniques and intraocular lenses. And if a patient wants to see at all distances of vision without aid of glasses, of course, you need to resort to a multifocal lens or a trifocal lens. And There are a plethora of such lenses, new technology that is coming up. And last but not the least is the increased refractive accuracy. Even if you perform a good surgery, take care of the astigmatism, use a premium intraocular lens, but if you have not calculated the intraocular lens power properly, it will come to a naught. You are not going to end up with a satisfied patient in spite of your best efforts. Now, I will not be talking about the hardware of the presentation, which means I'll not tell you how to do a keratometry. I would not tell you how to do a scan biometry or optical biometry, because these require hands-on. And I have done these talks, and they're all up in the YouTube, in the AIS, in my AIS website, editor processing site. So you can have a look at that, because for you to know how to do keratometry, how to do optical A-scan biometry, optical biometry, or other investigation, you require hands-on. You require the machine by your side. So it is not possible, in the short span of time that we have today, to tell you about the hardware. So my main focus is going to be the theoretical aspects, the software behind it. So over the years, the IL-PAR prediction has become very, very accurate. It's because we have had newer instruments and devices coming into the market. The formulas that we use to calculate the intraocular lens power, they have evolved, and we have very good formulas available today. Unlike 53 years back, when the first theoretical formula was published in the literature, and we have realized that there is a thing called a constant optimization of intraocular lens. Every type of lens has got a particular number. So we need to find out what that number is. And as I mentioned earlier, there are newer and newer instruments are hitting the market. They have very advanced features. But we must remember that we are in a developing country, and it may not. Most of the hospitals may not have the finances to access these state-of-the-art equipment. So we still have to depend upon the older generation machines, and they do extremely well. It is, of course, there in the published literature that those certain features may be absent in the older generation machines, but still, if you handle them correctly, if you interpret the results correctly, you get very good results out of these. And before I go further, I would like you to be familiar with certain names. They are basically the gurus of intraocular lens power calculation, the current gurus. This is Warren Hill of Hill RBF Formula. He maintains a website, and you will be visiting his website throughout your career as a cataract surgeon. Ken J. Hoffer Q Formula. Jack Holliday has done extensive work in IL-PAR calculations and in a lot of other field of activities in cataract surgery. The late Wolfgang Heigis from Germany. Thomas Olsen, Graham Barrett from Australia, the Barrett Universal 2 or Barrett suite of formulas, and the new kid in the block, Adi Abulafia, who is from Israel. So these are the people who have done extensive pioneering work in this particular field in terms of optimizing biometry or the formulas or how to get the best results out. And the literature is full of articles authored or co-authored by them. So they are the people you must be aware of who they are and what their contribution has been. Now, this is Sir Harold Ridley. He implanted the first intraocular lens 29 November 1949, and the results were not good at all. The first two patients, one had a overcorrection up to minus 21 diopters, and the second patient has minus 15 diopters. All right, so this is a result which is totally unacceptable today. So the surgeon and the IL manufacturing company realized that there has to be some modification of the intraocular lens design, and that was done. And the next audit cycle with 25 patients did better. They had a minus 2.25 diopter of spherical equivalent, but still the range was from minus 10.5 diopter to plus 4.5 diopter. So this was the early results, in the early 1950s, late 1949 and early 1950s. But how are we doing today? So this is the data that is available in the Warren Hill website. So only 1% of the cataract surgeons, only 1% who use this particular website are able to land 92% of the patients within a 0.5 diopter of the target refraction. Only 6% of the cataract surgeons are able to get the same level of accuracy for 84% of the patients. And for the vast majority of the surgeons, plus minus 0.5 diopter accuracy around the target refraction is seen about 78% of the patients, which is not a very good number. which means now these patients definitely, now 22% of the patients will definitely require higher power glasses. And if if I've promised the patients a life without glasses or reduced spectacle independence, they're not going to be happy patients. So we definitely have to do a lot to improve the scenario. And one thing a postgraduate student keeps in his mind is, the IOL power calculation is just a one-off event in the lifespan of the patient, in the lifetime of the patient. But what I would like to emphasize today is the IOL power calculation actually it transcends the entire perioperative period. There are important events happening preoperatively, intraoperatively, as well as in the postoperative period, which definitely plays a very important role in getting a good outcome for your cataract patients. So preoperatively, before you perform the scan, keratometry or the scan, you must examine the patient very thoroughly. You must have a look at the ocular surface. Last couple of years, we have realized that if a patient has an abnormal ocular surface, that has to be worked up and that has to be optimized. Patient counseling is very important because there are some patients who will be happy with no reading glasses. They want planar for reading, which means you have to overcorrect them. So there are a lot of other issues which you'll be learning during the next 3 years time. Biometric measurements should be made with a minimum of 2 devices, and again you use multiple, at least 2 formulas to calculate the intraocular lens power. And ultimately, once you have gone through that whole exercise, you select the appropriate intraocular lens for the patient. And during surgery, of course, as I mentioned earlier, the surgery has to be precise. It should be complication free. The lens should be kept within the capsular bag, and there has to be a 0.5 millimeter overlap of the rhexis margin on the optic side, on the optic anterior optic surface. So this is what intraoperatively, and postoperatively is the moment of truth. That's the time when you get to know how you have done, how your exercise in terms of IOL part calculation, how you fared in this exercise. So you get to assess your patients, the refractive outcome and the anatomic outcome, and then you take if the refractive outcome is not good, you may have to look into the reasons why it has gone wrong, and what could be done as a prophylactic measure for the future. And for the patients, what has gone wrong, there are various options, ways to correct them, to get them to the desired refractive status. So that is something that we as a surgeon will have to look into. So again, you have to use the right set of formulas, and when you take the measurements, make sure that you avoid the measurement errors, and that is by using certain validation guidelines. And I have already introduced you to the concept of lens constants, that each type of lens has a particular number, which may or may not tally with what is written on the cover of the lens. It may be written 119, but actually in your hands, the number may be 119.2. So that is something I will not be going into great details today, but that is important for us to keep in mind if you want to have a satisfied patient at the end of the surgery. So as regards the formulas, there are 7 generations of formulas, plethora of formulas, and we have stopped classifying the formulas in terms of generation. And this is the system that we follow. And historical refraction based formulas again has been given up because we have more sophisticated methods. Pure regression formulas again are not really used. So what is popular today are the Vergence formulas, and you'll be repeatedly hearing about the Holiday 1 formula, SRKT formula, Hoffa Q formula, Huygens formula, and then a Barrett Universal 2 and Holiday 2. And then there are certain formulas which are based in artificial intelligence. Artificial intelligence is playing a lot of important in our day-to-day activities in ophthalmology as well as including cataract surgery. So this is one aspect where artificial intelligence plays an important role, and that is the Hill RBF formula. And so now there are 2, if we have to know only 2 formulas for IOL part calculation, one would be a Barrett Universal 2 formula. So this is available free at the APSCRS website. It is actually a suite of formulas. It takes care of all your IOL requirement, IOL power requirement, all kind of situations and scenarios. And there are certain machines, higher end machines, optical biometers, which may have these formulas incorporated in their software. Likewise, the Hill RBF formula is also free. It is available at the ascrs.org website. And then this also is a very, very accurate formula. So today, whenever I do an IOL part calculation, I use only these 2 formulas. And then I find most of the time these 2 formulas speak in the same language. They give me the same numbers. If the numbers are not the same, if the oil part is not the same, there's a gross difference, then I'll look into other formulas and few other issues which is beyond the scope of the discussion today. So as I mentioned earlier, I mean, when you make the measurements, you have to make sure that the data that are feeding into these formulas have to be accurate. So you need to know how to avoid the errors in getting these measurements, and that brings you to the validation guidelines. See, for example, when we do the central corneal power, manual keratometry is most of the time we'll be doing. Reflective keratometry, which could be manual or which is automated, perimeter reflective keratometry. This should be high density. There's a lot of points on the corneal surface should be taken into account while getting the K reading. And today, of course, the central corneal power can also be obtained from the swept source OCT. This is an additional feature of these SSOCT devices. Axial measurements traditionally has been done with ultrasound biometry, A scan as well as B scan. A scan has fallen into disrepute because of a lot of nitrogen errors that happen. It is always examiner dependent, the way you conduct the examination, how the way you handle the probe and all that. So most of the time we would not use an A scan biometry, but maybe yes, we'll not be using a compression ultrasonic biometry, but we'll be using an immersion ultrasonic biometry if you don't have access to an optical biometer. Otherwise, optical biometer is what you have to go in for. And regarding measurement errors, for example, so if you may take the measurements and you find out that you're falling your corneal power, let's say corneal curvature is very flat or very steep, or the axial length that we measure in the length of the eye is very either very short or very on the extreme of ranges, and there is gross difference between both the eyes. And then this is just to give you certain important examples, and there is a whole list of validation guidelines which have to be gone through by the biometrist. And it is important that as a postgraduate student, even I also do end up doing a lot of biometry, because as a surgeon, as an ophthalmologist, you are directly responsible for the visual outcome. It is not the optometrist or the optician or the nursing personnel who may be doing these scans, but ultimately the responsibility has to be taken by the surgeon. So the lens constant is very, very important, and particularly when a new lens comes into the market. And so it is like in every type of lens, every type of design will have a particular number which has to be fed into the formula. Now, what is written on the box of the lens may not be the same in your hands, so it may vary. So we need to need to know how to calculate, how to optimize the A constant for the lenses that we're using. But if we're using a standard technique of cataract surgery, we do a 2.2 millimeter temporal clear corneal surgery, 5 millimeter axis, single piece hydrophobic acrylic design. So since almost of the surgeons follow this technique, so there is not much of A constant, variation, much of a variation in the A constant in the hands of surgeons who follow this technique and use standard techniques of optical biometry and standard techniques and the standard intraocular lenses which have international footprint. But problem starts when you have a new lens that is coming up in the market, when the lens constant optimization becomes very, very important. So friends, in summary, you must you should know how to take the measurements, and that comes hands-on. Use validated measurements. Make sure that the measurements are really the pure, that they give you good, proper, right information. Work with properly optimized lens constants, particularly for the newer lenses that are coming up in the market, and adapt to new technologies as they present. But you must remember that anything that is new is the best, or has to be adopted. No, there are certain new technologies which come up and then they disappear, they go away, they go into the oblivion. But you must be judicious in selecting a new technology which you feel it fills up the void and gives you better outcome, and strive to use all available resources to their best advantage for you to get the best post-operative outcome, visual outcome in your cataract surgery patients. Thank you very much for your patient hearing. And it was a pleasure, Rajiv, and congratulations to you, for organizing such a wonderful meeting. Thank you.